Dr. Usoro is the founding chairman of the Bloodless Medicine and Surgery Group at University of Calabar, a multidisciplinary group of professional volunteers providing bloodless care for patients, having excellent outcomes since 2007 as their inception. He's a member of many international professional societies, including Society for the Advancement of Blood Management, where he serves in a membership committee, and he's the founding president and current president of BMSS. He's a passionate about improving clinical outcomes, spreading the word around the world in terms of how well patients can do with this kind of thoughtful care and technique. He's a recipient of several awards, including the 2016 Savin Kathleen J. Sasma Award for Outstanding Leadership in Advancing Patients' Rights and Patient Blood Management. I am very honored to have the chance to introduce him. And Nathaniel, thank you for both making this happen, these meetings happen, as well as your passion, plus stepping in here to fill a void. Nathaniel, it's yours.
Thank you so much, Bruce. I need to mention that Dr. Spies is my teacher when it comes to bloodless care. And Dr. Newman came to Nigeria to teach us breast cancer surgery. So I have the best of both worlds. And since Dr. Newman has already spoken about a lot of the technical stuff in breast cancer surgery, I would just say a few words more on the bloodless side, as she has already said I should. So I do not have any disclosures, and I am certified in fundamentals as well as advanced concepts of patient blood management. Like I said, good teaching from SABM and from Dr. Spies. I'm also certified in bloodless medicine and surgery, even as recently as 2019. So having shared a bit of my credentials in bloodless, we want to see how we can explain what is wrong with blood transfusion in oncology. Thankfully, people who are better than me have done that already. On Monday, Dr. Blumberg spoke on that, and Dr. Refa also spoke on Tuesday. But we'll sort of review a few of the things they said. And we'll outline the principles of bloodless surgery and their application in breast cancer surgery, and then explain the benefits of bloodless care and why it should be the standard of care in breast cancer surgery. So breast cancer is the commonest malignancy of females worldwide. And about 25.1% of all cancers in females worldwide is breast cancer. Even in my setting in Calabar, it's even worse. 41.1% of all cancers in females, the Calabar Cancer Registry. And in my setting, it seems to affect mostly younger women, premenopausal. It's the commonest cause of death from malignancy in females worldwide after lung cancer. So why do breast cancer patients get transfused? Again, we had an idea of this earlier in the week, that cancer patients have anemia from disease, surgery, or chemo. And sometimes they suffer blood loss, could again be the disease. Breast cancer patients, like the advanced breast here that we see around here, they do bleed. And the surgery, of course, can lead to hemorrhage. So what do you mean by standard of care? The NCI, in the Dictionary of Cancer Terms, defines standard of care as a treatment that is accepted by medical experts as a proper treatment for a certain type of disease, and that is widely used by healthcare professionals, also called best practice, standard medical care, and standard therapy. Hitherto, it would have seemed that blood transfusion was like standard of care, but we're going to see why that title is slipping away from blood transfusion, going to bloodless care. So what is bloodless medicine and surgery? It is the provision of quality healthcare without the use of allogenic blood transfusion, with the aims of improving clinical outcomes and protecting patients' rights. So we are probably more familiar with the aspect of protecting patients' rights, but as we shall see, we have migrated from that, and you'll see why. So it's synonymous with transfusion-free medicine and surgery, and it encompasses, when we say bloodless medicine, we also mean bloodless surgery. And it's sometimes expressed as bloodless medicine or bloodless surgery. It's a multi-modal, multidisciplinary application of techniques tailored to the individual patient following a protocol. So it's not a one-man show. Neither is it one single technique, but a combination of techniques. Again, emphasis now is on improving clinical outcomes. And this early literature, the article in Transfusion by Goodenough and Shanda and Spence, defined bloodless medicine as referring to emerging clinical strategies for medical care without allogenic blood transfusion, a well-defined area in blood management. And this article by Martin and colleagues in the Theory and Practice of Bloodless Surgery, rather entitled The Theory and Practice of Bloodless Surgery in Transfusion and Apheresis Science, defined bloodless surgery as a comprehensive perioperative approach that has as its goal allogenic transfusion avoidance with a view to improving patient outcomes. So you can see the issue of improving outcomes has come into bloodless medicine and surgery. The authors admit that it was initially an advocacy, but they pointed out that it is a safe, effective team approach to medicine and surgery that reduces blood loss and uses the best available alternatives to allogenic transfusion therapy while focusing on the provision of the best possible medical care to all patients. Now, when you're providing medical care to all patients, that is no longer, you're not talking about an advocacy, you're not talking about patients who decline blood transfusion. So we are now moving towards standard of care. And why so? The same article says that recent evidence suggests that the application of bloodless surgery principles may result in improved patient outcomes, reduced morbidity and mortality, shorter hospital stays, significant overall cost savings to the health system. Does this apply to breast cancer patients? Certainly, we shall see. The article also points out that it was Denton Cooley and his group that actually popularized or rather advanced bloodless surgery, because they did what one did not think was possible, to do open heart surgery without transfusion. And unfortunately, it wasn't widely accepted because there were negative connotations attached to practice, seen as being associated with a fringe religious group. This is my own bit of contribution in a textbook of blood transfusion in clinical practice, defining bloodless medicine and surgery as the provision of quality healthcare to patients without the use of allogenic blood, with the aim of improving outcomes and protecting patients' rights. So again, the issue of improving outcomes. And of course, if we are able to improve outcomes, then we are dealing with something that should be a standard. Not surprisingly, the WHO came out with this policy brief, urgent need patient blood management. And they pointed out that the concept that our own blood is still the best thing to have in our veins has given rise to various surgical blood conservation techniques. Underlying these efforts is the broader concept of patient blood management. And they talked about the development, how it evolved. You can see those three pillars of patient blood management from the World Health Organization. Where did they get the three pillars from? Well, it was actually from the work of Dr. Denton Cooley in bloodless surgery. And you can see here a global definition of patient blood management by Shanda and colleagues, published in 2022, defining patient blood management as a patient-centered, systematic, evidence-based approach to improve patient outcomes by managing and preserving a patient's own blood while promoting patient safety and empowerment. Does that sound to you like bloodless surgery? If it does, it's because that's where it came from. As you can see here, that again, Dr. Denton Cooley is highlighted as having been the father of bloodless surgery, starting with Jehovah's Witnesses. And the three-step approach he used, now adopted by the World Health Organization and called patient blood management. So basically, this approach has led to a better outcome for patients, whereas blood transfusion, as you can see, it's in this article, there has been mounting evidence that blood transfusion is independently associated in a risk-adjusted, dose-dependent relationship with increased morbidity, mortality, and hospital length of stay. So that doesn't sound like what should be referred to as standard of care. If something is increasing the mortality, morbidity, and length of hospital stay. And so hence the tendency now for everyone to move away from blood transfusion, including in breast cancer surgery. So if you look at the definition of bloodless medicine and surgery and PBM, you can see the similarities. Bloodless medicine and surgery talks about quality healthcare, so it's not substandard care, while PBM talks about patient-centered, systematic, evidence-based care. And bloodless medicine and surgery talks about not using allogenic blood. And PBM talks of preserving a patient's own blood. And BMS talks of improving clinical outcomes, and the same thing with PBM. Then protecting patients' rights, which was where we started. That is patient autonomy and advocacy. That's where we started from. And the PBM is indicated as promoting patient safety and empowerment. So what is wrong with blood transfusion? Well, we are probably familiar with the hazards. Some may not realize that the hazards are different from the adverse outcomes. And then how many people know about the lack of efficacy? And is it really evidence-based? Is it ethical? Is it ethical, blood transfusion? Those are questions we need to think about. So we know about hazards, danger, risk, peril, threat, menace, jeopardy, chance, probability. We can take a chance, like crossing the street, which may be dangerous, but we cross the streets anyway. So doctors are used to balancing the hazards with the benefits. We have infectious hazard, non-infectious serious hazards of blood transfusion. The challenge comes when there is no evidence of benefits, as we shall see later. So we know a bit about the hazards of blood transfusion, and we may not need to go through each and every one of them, but there's quite a long list. And even the transmission of infection alone is a very big list. In my country, 95% of donor blood units are said to be unsafe. There's a warning by the experts, WHO, the medical authorities in Nigeria. Why? Because there are lots of transfusion transmissible infections, and a lot of them are endemic in my setting. And how many of them do we test for? It's only 4: HIV, hepatitis B and C, and syphilis, out of that long list. Now, let's move away from the hazards and talk about the adverse outcomes of blood transfusion. Should it be the standard of care? What are adverse outcomes? It's an unintended and unwanted event or state occurring during or following medical care that is so harmful to a patient's health that adjustment of treatment is required or that permanent damage results. That's not something we want. All doctors, we don't want to harm our patients, and we don't want any permanent damage resulting. Now, there is adverse outcome of blood transfusion. There are adverse outcomes of blood transfusion oncology, and breast cancer patients are not exempt. If you look at this early study by Crow et al. In 1989, they checked on transfused node-negative breast cancer patients. Those are patients that you would expect would have good outcomes because they are node-negative. But they noticed a decreased disease-free survival and overall survival. Subsequently, Bush et al. In 1994 reported 420 patients who had curative resection for colorectal cancer, curative resection, but they had higher local recurrence among those transfused, poorer disease-free survival. And both preoperative autologous donation and allogenic blood transfusion were associated with poorer prognosis. And Van der Watering et al. Also found in transfused colorectal patients lower 5-year survival. So transfusion is bad news in oncology, including breast cancer. Even when the blood is leukocyte depleted, it has been found that there's still increased problems like post-op ventilation rates, prolonged hospital stays discovered by Scanbeck et al. 2007, and Surgita et al. 2008 found in hepatocellular carcinoma resection patients lower 5-year survival. And they can actually have a risk of developing non-Hodgkin's disease, a different cancer entirely. So this article talks about blood transfusion promoting cancer progression. And that is something we don't want. So adverse outcomes of blood transfusion in oncology include increased post-op ventilation rates, prolonged hospital stay, reduced disease-free survival, higher recurrence rate, reduced overall survival, poorer prognosis, and increased risk of developing other cancers. The Society of Thoracic Surgeons have let us know recently, this is 2023, just last year, that even when we transfuse just 1 or 2 units of blood, there is still higher mortality, higher incidence of stroke, prolonged ventilation, renal failure, and reoperation, compared with patients who receive 0 RBCs. So those patients who receive 0 RBCs, what kind of surgery do they have? That's bloodless surgery. And so they concluded that this low volume transfusion is strongly associated with higher morbidity. This is just last year's publication. So should this be the standard of care? Certainly not. And we see here a question: why does intraoperative blood transfusion lead to worse outcomes? Well, mainly due to storage lesions and immunomodulation. Storage lesions, as we learned from Dr. Refai, lead to reduced tissue oxygenation. We tell our patients we're going to transfuse you so that to improve your tissue oxygenation, but it does the opposite. And was viscosity, aggregability, coagulopathy, a lot of problems come. Change in the morphology, and even the biochemical changes all lead to hypoxia, which this elegant study by Togeman and colleagues shows that the SpO2 is reduced in transfused patients, and it goes beyond just after 24 hours. So why are we transfusing them? We promise that we're going to improve their tissue oxygenation. I borrowed this slide from Dr. Spies. They can be up to 400% reduction in oxygen delivery due to transfusion. So immunomodulation is another big problem, leading to trialing, immune infection, cancer recurrence, and so on. And this is another borrowed slide showing that immunomodulation may actually be a #1 cause of death in transfused patients. An attempt is made in this slide and article to try to figure out why this happens. And there are lots of mechanisms which we may not go into, but the point is that there's increase in cancer recurrence rates by what percent? It can be up to 80% in colorectal cancer. And of course, post-op bacterial infections by how much? 200 to 1,000% in some studies. Does this affect breast cancer patients? Definitely. So it cannot be the standard of care for us to be transfusing. 100% of our patients have some form of immunomodulation or the other. And 100% of our patients have some level of decreased oxygen delivery. So we're talking of poorer prognosis in oncology. We're talking of higher infection rates, increased hemorrhage, higher incidence of ICU admissions, higher mobility, greater length of hospital stay, and higher mortality. And of course, there's a lack of efficacy. If it's causing hypoxia instead of improving tissue oxygenation, and higher mobility instead of lowering, and increasing mortality instead of lowering. So there's more that is known about the risk of blood transfusion than the benefits. This article in the Current Opinions in Anesthesiology said the benefits of blood transfusion have never been conclusively demonstrated, but evidence of transfusion-related harm continues to accumulate. So if there's no benefit, we're now moving beyond the issue of autonomy, which is still relevant, because as Dr. Blomberg pointed out, if we should have to tell our patients all the problems of blood transfusion, would they actually take a blood transfusion? So we just gloss over and tell them you need it to make you better. But if there's no benefit, then the issue of beneficence in medical ethics, that aspect is violated by blood transfusion. And if it is actually causing harm, higher morbidity, higher mortality, then non-maleficence has been violated. And if we only give the best to patients who decline what is causing adverse outcomes, are we being just? So we need to apply justice. If we know that some kind of therapy is beneficial, we should use it for all patients. So again, we noted why the breast cancer patients get transfused, but we also note that it doesn't really solve their problems. It makes things worse. Far back 2002, the World Health Organization told us that if we use simple alternatives to transfusion, even IV fluids, it's safer, less expensive, and maybe equally effective. A recent study, I think it was last year, published in The Lancet, compared transfused patients with hemorrhagic shock with those who were given normal saline. Shockingly, there was no benefit found in people in shock due to hemorrhage from trauma. So that brings us to bloodless medicine and surgery. And we can see those 3 pillars that Dr. Denton Pooley had enumerated or had pointed out: optimize hematocrit, minimize blood loss, support patient tolerance of anemia. And in bloodless medicine and surgery, we add optimized tissue oxygenation, which I think the anesthesiologists among us will be very happy about. So we already have heard much about optimizing the hematocrit, how we can use iron, that's the central thing, oral iron when possible, when feasible, parenteral, nutritional support, ESAs. We use them in our patients, breast care patients, including oral iron. Yes, it might not be very effective, but the background, we have found that, like in this patient, 55-year-old, who was started on oral iron from first visit, by the time we were set for surgery, our HB was 13.5. Before that time, it was around 10. But we use IV iron a lot. It's quite standard. We use it for every cycle of chemo and also perioperatively. This is that same patient had 6 cycles of chemo, and maintain the PCV well, because each cycle we give IV iron. This is a series of patients that had chemo and IV iron with each cycle. The question here, should intravenous iron be the standard of care in oncology? I'm sure we'll agree that yes, it should be. The issue of ESAs, Dr. Ford did justice to that on Tuesday. We have to be cautious. We will always give IV iron with ESAs, and we do not use ESAs in cancer if the hemoglobin is more than 12 grams per DL already. And we don't use it for cancer anemia due to disease only. That doesn't stop us from using IV iron. Though we know that when we add, adding IV iron to ESAs improves chemotherapy-induced anemia. So minimizing blood loss is important. I think Dr. Newman has said some bit on that. Starts right from the history. Want to know about bleeding disorders and address them. Stop medication that may cause bleeding during surgery. Restrict phlebotomies. Use tranexamic acid, very important, perioperatively, vitamin K and others. Non-invasive monitoring. Intraoperative techniques, of which we want to emphasize meticulous hemostasis. We saw a presentation Dr. Newman gave and how she goes about detecting very carefully. So in that outpatient pre-op HB was 13.5 grams per DL, third day post-op 10.6 grams per DL, using as many of those techniques as possible. So we do optimize tissue oxygenation, giving oxygen therapy when necessary. Even if the patient seems to be stable, but hemoglobin is less than 6 grams, we may give oxygen and then wean the patient off period. We replace volume, crystalloids and colloids. Colloids when the blood loss exceeds 25% of blood volume. And we try to resuscitate to the lower level of normal people. We make sure pain is taken care of because that can cause hypoxia, and sepsis, malaria, or any other underlying infections are treated. Very rarely do we use inotropic vasoactive agents. And of course, artificial oxygen carriers are experimental. And so we support the patient's physiological tolerance of anemia. WHO says we should do so. So we institute measures to ensure hemodynamic stability. We correct any electrolyte disturbances, limit patients' activity in moderate to severe anemia. Use point of care testing as much as possible. And we recognize that blood transfusion poses greater danger than anemia, and that with adequate support, patients have survived extreme anemia better without blood transfusion. I mean, it stands to reason if blood transfusion is causing hypoxia, then avoiding it would always be better. So faster recovery post-op, faster wound healing, lower wound infection rates, lower mobility, fewer ICU admissions, shorter hospital stay, lower mortality, avoiding of infections and other hazards, better prognosis in oncology, better patient satisfaction, better clinician satisfaction. And bloodless maintenance surgery is ethical, evidence-based. That sounds like what should be a standard of care, standard of care. We need to pre-plan, we need to combine techniques, not just one. Involve other disciplines and tailor our techniques to the individual patient using a protocol. And we emphasize education, not technology. This is an article from a Nigerian professor in nephrology advocating for the integration of bloodless medicine and surgery programs in the healthcare system of sub-Saharan African countries. And he says the bloodless medicine and surgery program is not for the sole service of the JW group anymore, but for the generality of humanity. That sounds like standard of care. And he says, he quotes Dr. Isbista. Says the blood transfusion was previously seen as a gift of life, but the tables have been turned. The general perception now is that bloodless surgery and avoiding blood transfusion may be the gift of life. So, bloodless care in breast cancer care be the standard of care? I think we can agree that it's the best practice. It should be the standard. And I've listened to Dr. Spee's lecture on this, and I am convinced that so should it be. And so we have May as Bloodless Maintenance Surgery Awareness Month, because these are things which, even though they are published, they are not widely known. They are not widely known by many people. And this week we focused on bloodless care in oncology and palliative care. And of course, today is World Bloodless Surgery Day, May 16th, in recognition of the great work of Dr. Denton Cooley. On May 16, 1952, his first bloodless open heart surgery, doing the impossible, because they used like 20 units of blood or more, and now he was using none. So for this year, our theme is avoiding transfusion, saving lives. Yes, both the lives of those who decline blood transfusion and the lives of those who may not know better. We as clinicians, we know better, at least in some things, while not being paternalistic, but we use the knowledge that we have. Later in the year, we're going to see how medical informatics advances bloodless medicine. What is medical informatics anyway? We'll have some great scholars telling us about that. So in conclusion, blood transfusion is not a scientific option for any patient because of its adverse outcomes and lack of efficacy. And it's particularly bad in oncology due to immunomodulation. Bloodless care in breast cancer involves use of evidence-based techniques under 4 pillars, which are simple, safe, effective, cheaper, and result in improved outcomes. Bloodless care is the ethical, evidence-based option for all oncology patients, including breast cancer patients. And this is one of my patients. She gave permission for us to show this picture. This was on the last day of our radiotherapy. So we were celebrating the last day of our radiotherapy. She had had bloodless mastectomy, bloodless chemotherapy, and of course, bloodless radiotherapy. And she did not object to blood transfusion because of religious beliefs. She simply preferred the better outcome and to avoid the problems she had noticed in those who took blood transfusion. So thank you very much.